Hi, my name is Dr. Sachi Marothra. I'm an orofacial pain specialist in San Diego. I work with Dr. Bradley Eli, and we have made this case report on atypical vestibular migraine and its response to various treatment modalities. So the aim of this case report is describing an atypical case of vestibular migraine characterized by periods of severe nausea, vomiting, and vertigo without any head or face pain that was initially diagnosed as Meniere's disease by an ENT, but did not respond to typical Meniere's treatments. And the patient presented to our clinic in 2020, and the symptoms did respond favorably to onabotulinum toxin A injections, which I'll now refer to as Onabot, and oral appliance therapy. And interestingly, it failed to respond to classic migraine abortive treatments and anti-nausea medications. So our case serves as an example that not all migraines fit the classic migraine criteria, nor are they accompanied by my headache symptoms always. All right, so the history of present illness. So this patient was a 38-year-old female. She presented to us in June of 2020. And again, we are an orofacial pain clinic, private practice. Her chief complaint was episodes of extreme vertigo accompanied by hot flashes and diarrhea and vomiting. And she had been referred to us by an ENT. These symptoms began in December 2019 and worsened in February 2020. She described these debilitating episodes of vertigo accompanied by hot flashes, cold sweats, nausea, vomiting, and feeling that the room was spinning. And then 30 to 45 minutes later, she would have severe exhaustion, which would make her fall asleep, and noted that her jaw pain and ear ringing were worse after these episodes of vertigo. These episodes would last anywhere from 4 to 24 hours. And like I said, they would be followed by exhaustion and weakness for about 2 days after. These were occurring about twice a month, and occasionally they would happen in the middle of the night. She ranked these intensity as a 6 and sometimes a 10 out of 10, with her average pain or discomfort being an 8 out of 10. And she stated that these episodes were so debilitating that they prevented her from working, and she was considering discontinuing work because of the disability of these attacks. And just a note, the technical definition of pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So although she didn't have any headache pain per se, she was able to give an intensity of pain or discomfort to these attacks of vertigo. She denied any ameliorating factors, but said that jaw function and tightness, and particularly when she was stressed, would aggravate or precipitate these attacks. She denied any precipitating events, notes a history of a nasal fracture at age 8, and had a significant medical history for Meniere's disease that was diagnosed 5 years prior. But she had never experienced this vertigo until 2019 when she presented to our clinic about a few months later. Previous treatments that she had done with an ENT were aimed for Meniere's disease and these vertiginous episodes, and they included an ondansetron and alprazolam trial, a right ear tube placement, steroid injections into the right ear, chiropractic adjustments, and a soft over-the-counter oral appliance. She worked as a surgical technologist, admitted that she clenched her teeth when she was stressed or when concentrating, and notes that she had stopped working for a period of 2 months, and during that time, she did not have any of these vertiginous episodes. But when she returned to work, she began to experience these episodes again. So that suggests possible stress-related correlation. So upon clinical examination, we found she was thin in stature, she had anxiety. A review of systems included nausea, vomiting, and diarrhea during these attacks. Her TMJ range of motion was within normal limits. It was 40 millimeters of active opening, 45 millimeters of passive opening. Lateral protrusion was about 6 millimeters, protrusion was about 5 millimeters, and she did have bilateral jaw pain upon movement. She had pain on palpation of bilateral TMJ capsules and bilateral masticatory muscles, temporalis and masseter. She did not have any joint sounds. She had some dental crowding in the anterior region bilaterally, and she was a Mallampati class 2. So our diagnosis at the time was vestibular migraine and TMJ arthralgia. So in this table here, you can see a timeline of all the treatments we initiated and her response. Let me zoom in a little bit. So at that initial consultation, we fabricated a temporary oral appliance. which she said reduced her jaw pain, and she wore that for about 4 weeks until we made her a custom oral appliance. At that consult, we did an in-office administration of Orofacial, 140 milligrams, which she said reduced the frequency of these vertiginous attacks. And she continued injecting them monthly for about 10 months, but then discontinued that due to insurance denial. At her first follow-up, we injected her with Onabot, and I'll discuss the protocol below. This led to a 60% improvement in her jaw pain and attack frequency. So she continued getting these Onabot injections at 12-week intervals, and she is currently continuing that treatment. So here you'll see our protocol for the Onabot injections. We have a pretty comprehensive protocol to address jaw pain, parafunction, headache. So in her case, since she noted some jaw pain and clenching, we did the masseter and temporalis bilaterally. We injected the periauricular muscles as well, and a few sites were injected in the frontal region and bilateral occipitalis. We used a 200-unit vial of Botox. Each site here marked with an X had about 2 units of Botox or Onabot per site. So we injected the procerus, depressor supercilii, and corrugator supercilii bilaterally, masseter, which includes superficial and deep masseter, temporalis, the auricularis anterior and posterior, and the temporoparietalis, and the occipitalis, distributing the Botox evenly between all the sites. So upon follow-up 2 or 3 weeks later, she did note significant improvement in the attack frequency after the Botox. At visit number 3, we fabricated her a custom mandibular flat plane orthotic, which replaced the temporary appliance she had been wearing, which she continues using, and said it reduced her jaw pain. And then at visit 3, we tried several medications, including rizatriptan, hydroxyzine for the nausea, fremanezumab, which she said was less effective than Orofacial, so she didn't continue with the fremanezumab. At visit 4, we did an SPG block, which caused her jaw to tighten. She thinks that when she was supine for the SPG block, that it led to dizziness and lightheadedness. And of note, the triptan trial, the hydroxyzine, she had no response, so she did not continue those. At a subsequent visit, we tried the dihydroergotamine methylate nasal spray, Migranol, with no response. It was not continued. And diazepam was also tried with no response. So after her initial round of Botox in June 2020, she continues to follow up for repeated Onabot injections. And since September 2020, she's reported only 1 mild vertiginous episode since. It lasted about 8 hours and did not progress to a full attack. And she ranked it a 1 out of 10 and noted that she didn't have any vomiting. So overall, no migraine abortive or antiemetics helped abort these vertiginous episodes, but she notes that currently chiropractic adjustments every 4 weeks for neck and spine adjustments, along with the Onabot injections every 12 weeks, and her nightly orthotic use are pretty effective in keeping these episodes well managed and relatively infrequent. So she continues to follow up with us every 12 weeks for the Onabot injections. So typically, migraine attacks are characterized by unilateral head or face pain of moderate to severe intensity, lasting 4 to 72 hours, usually accompanied by nausea or vomiting, photophobia and or phonophobia, and often followed by postdromal symptoms, including exhaustion. Vestibular migraines include vestibular symptoms, including vertigo, nausea, and dizziness, lasting 5 minutes to 72 hours. So although this patient's migraines did not, or these episodes did not include classic migrainous features like the headache and head pain or photophobia, phonophobia, the duration of these attacks was consistent with migraines. And she did have the accompanied nausea, vomiting, and postdromal exhaustion. So this case serves as an example that orofacial pain specialists can identify and treat unusual symptoms even when they don't present as classic TMD or facial pain. And in this case, the duration of the attacks was the indicator that this was probable migraine. Furthermore, she responded very favorably to the Onabot injections and the CGRP monoclonal antibody trials, which also supported the diagnosis of vestibular migraine, as those are known to be prophylactic treatments for migraine. And interestingly, she didn't respond to the rizatriptan or DHE, which are common migraine abortives. And she did not have any response to the anti-nausea medications as well. Her concurrent diagnosis of Meniere's may have contributed to the vertiginous symptoms, but she continued to experience these attacks despite those Meniere's treatments she had done with her ENT prior to coming to us. So currently her TMJ arthralgia remains well controlled with her orthotic use every night and with the quarterly Botox injections. And given her report of jaw tension and stress-induced parafunction as a trigger for these episodes, we felt that the placement of Onabot into the masticatory muscles was warranted. Interestingly, the chiropractic adjustments for her neck and spine have benefited her. So I know these aren't often considered as treatments for migraine, but it's often considered as an alternative and concurrent treatment. That suggests possible neck involvement as a migraine trigger for her. And of note, she didn't experience any vertiginous episodes during that 2-month period where she didn't work. So that suggests that work-induced stress may have increased her parafunctional activity, thereby increasing her jaw tension and precipitating or contributing to these vertiginous attacks. So in conclusion, although her vertiginous episodes didn't present as classic migraine, the timing of the attacks and her response to these prophylactic treatments and equivocal response to the Meniere's treatment suggests that the vertiginous symptoms were due to vestibular migraine rather than Meniere's disease. So given the duration of the episodes, the accompanying nausea, vomiting, the post-stromal exhaustion, we suspected vestibular migraine. TMJ arthralgia and masticatory muscle tension can contribute to migraine, and as evidenced by this report, they should be addressed when present in migraineurs. And oral appliance therapy is an effective way to unload the TMJ and reduce arthralgia. In this case, it was a helpful adjunctive treatment to reduce her frequency of these migrainous episodes and address her jaw pain. So overall, I think basic understanding of migraine characteristics and variants is an important part of comprehensive patient care when treating orofacial pain. Like I mentioned earlier, this case initially didn't sound like something within our scope of practice, but once we took a really careful history and picked up on the duration and the accompanied symptoms, it was something we felt comfortable in treating. This case report demonstrates the importance of careful history taking and attention to features such as the pain duration and associated symptoms to help identify and correctly manage these atypical presentations of common facial pain complaints. Prior to her consultation, this patient's quality of life was significantly diminished to the point where she was considering discontinuing work because her attacks were so disabling. And now, I'm happy to report she currently continues working, and her attacks and jaw pain are well managed with these conservative treatments that are well within the scope of an orofacial pain practitioner. Thank you.